So we are going to start antenatal module, and in antenatal module, everyone was very stressed out regarding small for gestational age Green-top Guideline, and even my theory course students requested me again that, ma'am, please repeat it again, revise so that we can revise it. So this is, uh, predictable disclaimer that this is a difficult guideline, right? And this is not only for important for your like RCOG exam, this is also very important for your yes, Fatma, you are right. This is also very important for your CPSP exams as well. As you people know, nowadays, extended talks are going to be actually held. And yesterday exam, there was a station on SGR, FGR, and with interpretation of Doppler as well. And obviously, this is very hot favorite topic, and whatever exam you are preparing for, I will try. You can easily approach your not only written but also your talks. So, in the end of this theory lecture, I have added some scenarios which has been tested in your talks ROSC exam as well. And practicing clinical scenarios are more better if the topic is already very complex, because through clinical problems you can correlate your theoretical knowledge well. Okay, so let's start what we have. Yes, SG guideline, we are starting with some positive quotes, motivational quotes that all dreams are within reach. All you have to do is keep moving towards them. And before this, I will start your boring theory lecture. Let's revise what you already know on this topic. See, okay, so how we will start? If we want to make any dish, there are certain recipes which we have to follow. And before that, we will start cooking. We have to learn about ingredients, right? So just imagine that SGA is actually a dish which we are going to cook today, right? And before this, we can cook this dish well. We must know the ingredients, right? So ingredients which we will require to prepare this dish are, you must know certain definition. What is SGA? What is FGR, right? And why pregnant people are at risk of having SGA? And what are those risk factors? How we should type them? Like we can type them maternal causes, we can type them on placental causes or fetal causes, right? And also we can type the risk being low risk, being intermediate risk, or being high risk. And also we can type them, if it is SGA, we can type them symmetrical FGA, FGR, or asymmetrical FGR. And even then we can go more actually beyond than this, and we can say this is early onset FGR or late onset FGR, right? So far, again, I'm going to revise, and I will keep revising you people. The SGA dish, how you can cook it. The single most important ingredient to actually cook it well, which is your SGA and FGR definition. Don't forget it. What is SGA? What is FGR? How you will type them, and actually what are the risk factors on which you will be at the time of booking very careful that you will plan certain protocols that this patient is, high low risk. I will just do symphysial fundal height measurement, take only symphysial fundal height measurements, and this patient is having intermediate risk. I will just add in third trimester serial scan, that's it. But this patient at booking having established risk factors, this is that patient which will take aspirin as well, and I will keep an eye on her, and I will give her special protocol so that this high risk patient with having right now high risk factors, yet not it is FGR, but she can develop FGR anytime. So I will plan certain protocols through which I can prevent this condition or can detect earlier. Prevent we can like by adding timely timely low print, and detection will be certain Dopplers. Right now, just understand like this. Okay, so definition is, the basic ingredient. Okay, after the definition, let me to check. Yes. Okay, after this, we will check about monitoring tools, right? What are the basic monitoring tool? Basic monitoring tool for FGR, RI, SGA. It is Doppler. So before this, we should start reading this guideline. We must understand the type of Doppler. There are certain type of Doppler, like earliest Doppler is uterine artery Doppler, and then umbilical artery Doppler. Then there is middle cerebral artery Doppler, and before middle artery Doppler, there is ductus venosus as well. So we can cook our dish better if we know. We can actually understand the Doppler, type of Doppler, and their interpretation, how they look, and if they are bad, what to do next, right? And third most important thing, which is quite new for you people as well, and you can say that we can't make any delicious cook if we will not add any salt. So salt in this SGA dish is, guess what? What it is? It is it is STV. Have you heard about STV? Anyone? STV, short-term variations. These short-term variations we can't see on routine CTG, but computerized CTG can actually predict STV pattern, right? So during our FGR journey, we will see that at various checkpoints, we have to take the decision urgently, right? We can't actually prolong the pregnancy. So STVV is among those checkpoints. If STV is bad, we may plan to terminate the pregnancy there and then, whatever is Doppler, right? Whatever is Doppler. And I told you people that this new guideline has been tested recently in your TOEIC ROSCE exam as well. And the magic was this, the buzz was this STV. Okay. Okay. So please keep yourself on mute mode. Iram, I'm going to mute you. Okay. Let's start cooking. Ready to cook, FDR? Okay, let's start. So, there are certain actually risk factors. I already told you people. Like they can be maternal, they can be placental, they can be fetal. If patient is having them at the start of pregnancy, there are more likely chances that she can end into FGR, right? So we will divide them into three parts so that you can understand them well. So yes, number one, maternal. Maternal, it can be malnutrition, it can be smoking, it can be substance abuse, it can be alcohol, it can be diabetes, it can be chronic hypertension, it can be autoimmune conditions like APLS, SLE, it can be hematological disorders like sickle cell disease, it can be previous FGR. For the sake of simplicity, just focus on the risk factors. Right now, don't bother what risk factor is high, what risk factor is low, which risk factor is intermediate. First thing is that you must actually categorize them into types. These are the maternal types, these are the placental types, and they are the fetal types. So in placental types, it can be gestational hypertension, it can be CKD, previa, abnormal cord insertion, cord abnormalities, post-date pregnancies, or preeclampsia. And all these factors actually are also reason of the main reason behind FGR is placental insufficiency. In placental factors, it's quite logical. And the third thing is fetus itself. Fetus can be more than one. They can have congenital disorders. They can have Dawes infections, right? So broadly, we will divide risk factors of fetal growth restriction. Number one, maternal. Number two, placental. And number three, fetal. I will suggest you people do not just cram FGR for your written exam purpose. If your focus will only will be what you actually your written exam, you cannot understand the gravity of this condition, and you will again face problem when you will sit in your OSCE. So there and then prepare this topic simultaneously for your written exam and for your OSCE exam. And preparing for OSCE exam, again, I am telling you, will give you more clarity. You will be more actually good in your concepts and your approach. You are picking your theory questions as well, right? Okay. So when you will take history from the patient or the role player during your OSCE exam, you actually can't take history like this. Let's start from low risk. Let's start from intermediate risk. Let's start from high risk. Your mind cannot process like that. However, your mind will definitely process the questions if you will divide it into maternal, into placental, and into the fetal categories, right? That's why I am putting effort on this. Though it's not GTG, GTG stable, even then I'm actually putting effort here so that once for all you can grasp this topic. Okay. Now, forget about the low risk. Low risk means it is not the patient is not having moderate risk factors, neither it is having high risk factors. So it will be definitely low risk. Good. Okay. So let's start from the obstetrics risk factors. Why we are concerned on risk factors? How we will actually correlate it? Assume a patient, any patient, ABC. You are actually she is visiting first time. in antenatal OPD and you are checking her first time and it's her 12 weeks. So this is the right time to develop her antenatal care plan. How you will care her antenatal plan? Obviously by taking quality history, right? So you will ask about, presenting complaint. If she has on any, then you will ask about the pregnancy itself, spontaneous, planned, medical disorder, surgical, blood, drugs, allergies, previous OBS history, how she conceived, number of deliveries, mode of deliveries, any complications, so many things you will ask. And you will keep checking every component. And if you will see that the patient is having high risk condition, you will circle it, you will mark it, and on these risk factors you will actually develop her plan, right? This is the natural flow. Just imagine you are sitting in antenatal OPD, a patient came to you and she's at 12 weeks. So you will ask about, definitely you will fulfill all components of history. Think about the OBS history. She is giving you history that her previous baby was small for gestational age. Her previous baby, her previous pregnancy ended in stillbirth, and that was appropriate for gestational age baby. Her current pregnancy, she started smoking, or she is using some alcohol. And at the time of current pregnancy, she's at 40 or more than 40. Her BMI is less than 18. She's having certain eating disorders. She's having certain bowel conditions causing weight loss, right? She's having gastric bypass surgery. She's having past pregnancy complications which ended into the preterm birth. She is giving you history of second trimester placental related miscarriages. So you will obviously underline all these things. And if she is not having high risk factors, not having low risk factors, having moderate risk factor 1, 2, 3 are all, still you will put her into this moderate risk category, and you will advise, and you will write on her antenatal care plan that she must start serial growth scan at 32 weeks because she is having moderate risk factors. She is having moderate risk for developing FGR. So we will keep an eye on her, and on the basis of all the data which we have, checked via history, which she is entitled that we should plan her 4 weekly growth scan, right? However, the same patient, ABC patient, which you are actually checking at 12 weeks, having chronic kidney disease, having certain autoimmune disease, having previous pregnancy with FGR, history of preeclampsia in previous pregnancy, or having previous SGA stillbirth, or in current pregnancy at 12 weeks, her combined test screening comes abnormal, and combined test screening, Papa comes abnormal. Placental associated proteins which are less than 5th percentile are less than 0.4, are having inhibin more than 2, are alpha protoprotein after 15 weeks more than 2, are having echogenic bowel on scan, at anomaly scan, are having heavy bleeding, are in this current pregnancy, she is having estimated fetal weight less than 10 centiles, are having single umbilical artery. So all these factors will make her very high risk. You give her additional protocol, right? And this protocol is when you will do her anomaly scan, at the time of anomaly scan, or you can say 18 till 23 plus 6, you will advise her that her uterine artery Doppler should have been done because she is high risk. Right? So if she's low risk, you will do nothing. No growth scan, no Doppler. If she's having positive moderate risk factors, you will advise she should have serial growth scan only, no Doppler. Serial growth scan only from 32 weeks and 4 weekly. And if she's having high risk factors, then you will give her additional protocol and you will add Doppler here. The earliest Doppler which we can do is uterine artery Doppler. So, and the timeline is 18 till actually before 24 weeks. You can say 23 plus 6. And this is the protocol actually for on the base of risk factors, right? So far clear? So far clear. Yeah, right, you can write in chat box. Okay. So, okay. So the patient with who is high risk, right, having high risk factors, and she's having normal uterine artery Doppler, which we have done 18 till 23 plus 6 or before 24 weeks. So what we will do? We will advise her. We will actually monitor her like intermediate risk factor because she is having normal uterine artery Doppler. And what we will see, what we will do, we will advise 32, from 32 weeks, her growth scan. Growth scan means fetal biometry and Likert assessment, right? From 32 weeks. That's it. No Doppler here because this is normal. Now you have done uterine artery Doppler because she was high risk and it comes abnormal. Abnormal means like you have seen pulse rate index more than 95th percentile are having notches. It's mean she was high risk and her uterine artery Doppler is also actually predicting that she can develop FGR later in this pregnancy. So this is better if you can start earlier intervention, earlier monitoring. And this is that you will advise her. Now we will add Doppler with growth scan and not from 32, which we have done with intermediate risk factor conditions or those high risk conditions where uterine artery Doppler was normal. Because now it is abnormal, we will start monitoring earlier, right? So 24, 26 is earliest time, and maximum you must start by 28 plus 6 weeks. And we must add, because uterine artery Doppler is normal, another Doppler is also important, and this is umbilical artery Doppler, right? So we have learned a patient, Mrs. ABC, comes in antenatal OPD at 12 weeks. We have taken her thorough history because we always take thorough history of every patient at booking, so we can give her, stickers. Okay? So we have taken thorough history and we have given her sticker that she is low risk. And we will actually there is no consultant advice is needed. But if we have taken the history and she comes with intermediate sticker, and then we will plan that her growth scan only will be done from 32 weeks, 4 weekly. And on the base of history, if we have given sticker of high risk conditions, then we will add uterine artery Doppler. And this uterine artery Doppler is very important. If uterine artery Doppler is normal, then we will do like what we have done with intermediate. But if it is abnormal, then earlier, 26, 28 weeks monitoring with growth scan. And additional to this, because it is abnormal, we will add umbilical artery Doppler as well. By the way, umbilical artery Doppler, if they ask you what is the primary surveillance tool in high-risk pregnancies, it is uterine artery Doppler, it is umbilical artery Doppler, is it middle cerebral artery Doppler, is it ductus venosus? So you have to pick, it's only umbilical artery Doppler, right? So abnormal uterine artery, so we will add abnormal uterine artery, so we will add umbilical What I am telling. Uterine artery Doppler abnormal, we will add umbilical artery Doppler. This sounds really familiar, right? So be careful. Okay, girls and boys. Moving forward. Have you noticed when we were checking risk factors, intermediate and high risk, some things were looking same, but yet they were not same. So I am particularly highlighting them. If a patient is having previous SGA without confirmed FGR, means no Doppler problems, no severe growth restriction like less than third centile, then this is only SGA. This is intermediate risk factor. But if her previous pregnancy was confirmed FGR, then this is high risk. So previous FGR is different. Previous SGA without confirmed FGR is different. In exam stress, when you are solving a lot of questions, and you will face such question, and where you have to actually interpret the data in hurry, I'm sure you will forget this point, but do not forget, please. At that time, I I will be going in your ear. Don't pick it because it is only SGA. This is only intermediate risk. And if it is proven FGR, then this is high risk. And it will change your key, because if it is high risk, you will add uterine artery Doppler. If it is intermediate risk, you will just add growth scan from 32 weeks. So the key will change. And apparently you will feel they are same, but they are not same. Clear? Am I clear? Okay. Chalo. Okay, so next. Next is previous stillbirth. But the stillbirth was of appropriate for gestational age baby. And here, high risk if previous stillbirth of because of SGA. Got it? A normal AGA baby will die before labor or during labor. This is intermediate risk condition. We will do only 32 weeks monitoring onward. But if her cause of death was SGA, then what we will do? Uterine artery Doppler. Got it? Another very important thing is previous preeclampsia. Previous eclampsia is always high risk. And previous eclampsia, you will definitely add low preem as well. Right? Previous preeclampsia or previous preterm birth because of before 32 weeks, because of placental disease, they are high risk conditions. So intermediate risk conditions, previous SGA without confirmed FGR, previous stillbirth of normal AGA baby, and current smoker, this label. This is very unique. So these two things you should not mix, please. Don't do this. Okay. So far, where we were preparing our dish, FGR dish, and we have just actually revised risk factors. Earlier, we divided these risk factors into types like maternal, fetal, placental, and then we divided them into low risk, intermediate risk, and high risk. And on the basis of this intermediate and high risk, we have noticed further unique interventions, right? And we have also compare apparently similar looking information, which is yet not similar and having certain differences. Now, important gradient is charts. You will see in your written exam as well, growth charts and fundal height charts, and also in your OSCE exam as well, and you have to interpret them. So let's start. Apparently the chart of fetal growths, neonatal growths, adult growths, fetal growth and fundal height look same. If you will read, then you will feel the difference. They are different. So, but they have written here. This is my pencil. Okay, it's here. Okay, so this is, they have said this is fundal height. Obviously, this is fundal height, so this growth chart is about fundal height, right? But is customized symphysial fundal height, serial fundal height plotted on an appropriate antenatal chart chosen by the unit. If below 10 centile are no growth over 2 weeks, refer for ultrasound. So in hurry, you will see this chart as growth chart. This is not growth chart. This is symphysial fundal height chart. And if anything is abnormal, like fundal height is less than 10 centile, or static over 2 weeks, then you will not refer her directly towards fetal medicine unit. First, you will confirm it via ultrasound. And symphysial fundal height is not important in various conditions, like patient is obese, her BMI is more than 35, or she is having, fibroid. Then you will directly go and request that she is perfect candidate for serial growth scan, because in her case, customized fundal height is not important, and always opt customized fundal height. It's mean you must have her data like her age, race, ethnicity, right? And then appropriately you will plot it, and it will be more error free as compared to any random fundal height charting done by any random person. If it is customized and done by the same person every time, then the chances of error are very low, right? So here it is gestational age, and here this is fundal height. And if the information is falling here, it's mean it's less than 10 centile, so that you will refer her for ultrasound, right? Okay. Next, this topic, I'm sure you have not done this. The way I'm going to revise it, you have not done it earlier. And it's very important. It will change your management at various points in your theory exam, in your OSCE exam. This chart is not, looks like fundal height customized chart, but it is not. It is fetal growth chart, right? And you have to interpret it in quartiles. What are quartiles? Quartiles mean first quartile, 25% of the babies. Second quartile, in which 20, it will start from 25th to 50th. Means 20-25% in each quartile. So there are 4 quartiles which will make 100%. Right? Just imagine, just take the concept of quartile. And in coming slide, you will notice that why we are reading these quartiles, why they are important. So if a patient is actually, we said that she's intermediate risk factor, and we advise her that her growth scan should be done from 32 weeks. And now we have 2 to 3 growth scans. So how we will compare them? We actually plot them on this graph, the graph like this. Here we will write week of gestation, and here we will write the estimated fetal weight. If she is at 32 weeks and her estimated fetal weight is somewhere at this timeline is somewhere at 33.2 kg. So it's more than 90th percentile. Here we will say this the patient is at risk of large for gestational age, and we will evaluate her for diabetes, for other things, fibroids, tumors, cysts, obesity, so many things, poly, twins. And if the same patient, another patient who was actually already on our radar having intermediate risk factors, and we have noticed that her first growth scan started at 32, and then 4 weekly we have done another 136, and her meeting point is this, then it is less than 10 centile. This condition is that she's having right now SGA. On growth charts, we can actually pick SGA, and we can also pick FGR. How? And we can also pick LGA. If her meeting point is somewhat like here, then we will say that she's having condition large for gestational age. If she is falling in this line, then she is at appropriate for gestational age. If her as per her gestational age, her baby weight is falling here, then we will say that it is for small for gestational age, right? So more than 90th, large for gestational age, and less than 10 centile is small for gestational age, and anything between 90th and 10th is appropriate for gestational age. But if at single point we notice that growth is that much restricted and it is here somewhere like less than third centile, so we this is not SGA. That much severity we can only notice in FGR, right? So on growth chart, we can pick large for gestational age babies, we can pick appropriate for gestational age babies, and we can pick small for gestational age babies, and we can also pick very growth restricted, which is less than third centile FGR babies. Got it? Am I clear so far? Girls.
Excuse me, ma'am, I have a question, please.
Yes.
Ma'am, you are teaching about quartiles. Are these specifications are for SGA only?
No. You will let me to clear my point. And after this, you can ask query. And I will request you, let me to complete my all slides. And then you will notice there will be not a single question which you will think will be missed, right? Okay. So when you will read your Green-top Guideline 2024 in late onset FGR, you will notice that they are saying that if any two factors positive, then it is late FGR, and among them one is crossing centile, crossing more than 2 centiles. Have you heard about it? Crossing more than 2 centiles, what does it mean? So it's mean you are following a case like intermediate or high risk, and you noticed that her current scan is having, her previous scan was having estimated fetal weight on 75th centile. And her current fetal weight is on 10th centile, not less than 10th centile. Right? Means like you will appreciate that earlier her growth was at 75th, and now dramatically it is reduced more than at 10th or equal to 10th centile. And this difference is huge, and more than 2 quartiles has been crossed, 50th and 25th quartiles. So this is abnormal change in growth velocity. And this is very important if you are dealing a case or pregnant woman who is coming to you at or after 32 weeks, because it is important. And if anything is off in her risk factors with this condition, you will not say this is AGA. By definition, it is AGA, because it is between 90th till 10th centile, right? This condition is still, as per definition, between 90th and 10th centile. You will apparently notice that this is okay, fine, and you will actually not appreciate it, and you will not actually appreciate the sudden change in change in velocity, which is reducing dramatically. So this is important. Crossing, if you see after or at 32 weeks gestation, growth scan is of a baby crossing 2 quartiles, the baby is not normal. Baby was earlier growing normally, but has dropped markedly on serial growth chart, suggesting placental insufficiency. However, baby is still above 10th centile. But if it drops sharply from a high centile to a much lower centile, it can still be concerning. For example, earlier the baby was on 90th centile, but now it at 25th. So the baby growth has crossed 2 quartiles. The baby is not small right now, but growth velocity is abnormal. The fetus was growing on higher centile before, but on the next scan, it has dropped across more than 2 centile. Got it? So this is important. Always appreciate this difference. Specifically, you will notice it when you will ask from examiner, give me her growth scan, and she will provide you, and you will say, oh, everything is okay because more than, the baby is still more than 10 centile. No, it's not okay if the patient has, crossed 32 weeks. So far, am I clear? While crossing centile. Okay, so
Excuse मैडम,
yes.
मेरा एक क्वेश्चन था, ये जैसे हम ये कर रहे हैं सीरियल ग्रोथ चार्ट्स, तो ये कितना टाइमली हमने रिव्यू करना होता है इसको, कि जिसमें हमें ये मतलब हम पिक कर सकें इसमें?
ओके
ये भी 2 वीकली या 4 वीकली हमने रिव्यू करना होता है चार्ट्स?
If we are following SGA case or FGR case, right? Then it is 2 weekly. If we are following risk factor based case, like patient is having just risk factors, not developed anything bad, like earlier we said that intermediate risk, we are following her 32 weeks, we are doing 4 weekly scan, right? So on risk factor based assessment, we will do growth scan 4 weekly. If on this information anything odd, we will bring her towards more closer line, and it will be 2 weekly then. Okay.
Thank you.
Okay. So next. So now right time has been closer, and this is the difference between SGA and FGR. Okay. So okay. So this is visual picture, SGA versus FGR. Here you will appreciate this is having estimated fetal weight less than 10 centile condition with normal Doppler. So this is SGA. But the same baby is if having abnormal Doppler or normal Doppler whether, but estimated fetal weight or AC, any among these two is less than third centile, then this is FGR. This is basic visual actually concept. Okay. Okay, so SGA means birth weight less than 10 centile, AGA means between 10th and 90th, and FGR means same baby with less than 10 centile estimated fetal weight plus abnormal Doppler or whatever is Doppler, but having severe growth restriction, which is less than third centile. It is not SGA, it is FGR. Now, think about another exciting ingredient in your FGR dish. This is type of FGR. So we can divide it into many types. Like we can divide in type 1 and in type 2. We can divide into early and we can divide into late, right? See, type 1 we can say symmetrical, type 2 we can say asymmetrical. So type 2 asymmetrical means then AC is dropping more as compared to HC. So there is disproportion. In symmetrical, both HC and AC dropping equally. Both are FGR because they are dropping their weight. But type 1 condition associated with equal drop in HC and AC. And in type 2, there is actually disproportion. AC is dropping more as compared to HC, right? So we can say this early as well. Type 1 can be early and type 2 can be late. Type 1, usually we noticed earlier, and as we are noticing it earlier, then the probability of having placental disease is less. We will see more actually causes which are having torch affected conditions, congenital disorders, or maternal factors. Right? Type 1, symmetrical, early cause is torch, chromosomal problems. In it, both HC and AC are less than 10 centile, brain affected, but the ratio is equal. In type 2, which we notice in late, second or third, and they are more common as compared to type 1. And they are associated with more adverse effects as well, right? And 70% reasons are of placental insufficiencies because second wave of trophoblastic invasion, we see it comes, after 20th week, and after 20th week, because of placental mediated conditions, which are gestational conditions, diabetes, hypertension, or even existing complicate more. So we notice this pattern after second half, in which AC basically drop more than 10th percentile. Got it? Now think about a condition in which a patient was having type 2 asymmetrical FGR. And when you were following her, she developed symmetrical FGR. So this is good thing or bad thing? Earlier, her only AC was dropping. Her HC, her brain was actually compensating. But now her brain has stopped to compensate and it become smaller. Both are dropping. So this is bad. Got it? In type 2, if asymmetrical FGR becomes symmetrical, this is not a good thing. This is bad thing. Okay? Now, again, I'm just giving you people a visual picture. This is normal head, normal baby, and more than 10 percentile. This is also normal head, small abdomen, looking actually appropriate, but appropriate more than 10 centile. Here appropriate, looking appropriate, but growth is less than 10 centile. So this is normal and this is symmetrical. Heart type 1. This baby is AGA, appropriate for gestational age. This baby is SGA, type 1, because symmetrical. Drop in HC and AC, and it is type 2, asymmetrical. Head is compensating because of brain sparing effect. Abdomen is not compensating and has been dropped more less than 10 centile, and this is asymmetrical. Right? Okay. So symmetrical IUGR, an insult that has occurred early in antenatal period during the period of germinal organ growth. The main associated conditions are congenital chromosomal abnormalities, infections, and early environmental factors. It can be, by the way, early placental disease as well, but less likely. So just imagine a patient who came at 20 weeks and having symmetrical IUGR. What is more important? What investigation is more important? Doppler or those tests which will comment on chromosomal abnormalities or infection? Main cause at 20th week of symmetrical FGA. Yes, you are right. Main cause is chromosomal problems, torch, and for those both conditions, we will first do amniocentesis to exclude these two things. Because at 20 weeks, it's less likely we will notice symmetrical IUGR. IUGR has been replaced now with FGR. But if the same patient, we are actually looking at her after 24 weeks, and she's having asymmetrical growth issues, then we will not opt amniocentesis, because we know this is the time where placental diseases are working more. And for them, the best investigation is not amniocentesis. This is Doppler. As I told, more than 24 weeks. So this is not uterine artery Doppler. This is umbilical artery Doppler. Once you have crossed more than 24 weeks, no role of uterine artery. And if uterine artery earlier, if it was normal, abnormal, and become normal later on, it has no role. Uterine artery has only predictive role, no role in monitoring, and no role once 24 week has been reached, and has only role in high risk factor conditions, not in low risk, not in intermediate risk. Please register this. Okay. Now, asymmetrical FGR. The fetus responds to inadequate supply of nutrition by redistribution of blood flow. More goes to the brain, heart, and adrenal glands. Less goes to the liver and kidneys. Consequently, the abdominal girth and fat stores are reduced more than the head. This is known as brain sparing effect and is usually associated with pathology of later onset, such as preeclampsia, idiopathic FGR, are associated with essential hypertension or maternal smoking. Okay. What is constitutionally small fetus? It's mean normal growth curve, normal umbilical artery Doppler, and normal amniotic fluid volume. I already told you people. If growth is less than 10 centile, rest Doppler is okay, and growth potential is okay, Leica is okay, we say this is SGA, and its reason is more likely constitutionally small fetus because of parents' conditions. Parents, their self are small parents, small babies. Got it? Okay. Chinese have, smaller population. Africans different. Asians different. So, but Green-top Guideline 2024 has given definition, different terminology. This is, we will say, in next slide, I will show you. Yes. Early FGR or late FGR, right? So what is early FGR? Early FGR is less than 32. You will face a lot of difficulty if you are not registering it. If a patient is coming at 32 weeks with FGR, this is late FGR because here they have written equal and more than 32. It's mean 31 plus 6, right? Before 32, if patient is having AC or estimated fetal weight less than third centile, with or without abnormal Doppler, this is FGR, this is not SGA. Or having less than 10 centile with abnormal Doppler, right? This is FGR, this is not SGA. Got it? PI of uterine artery and umbilical artery is same. PI means pulsatility index. If it is more than 95th centile, it is abnormal. But yet when we will interpret Dopplers, among all Doppler abnormalities, this is good pattern. PI is good as compared to absent diastolic flow and reverse flow, right? However, it's not mean that it is good. This is bad, but marker of severity is good as compared to absent and reverse. Now coming towards the late FGR. Late FGR means we have noticed or diagnosed FGR at 32 or over. In the absence of congenital anomalies, in the absence of fetal infections, either directly less than third centile, like earlier FGR, or it is different. The basically early FGR and late FGR having same definition if ACR, estimated fetal weight, is less than third centile, right? But in late FGR, we here they said only one Doppler is bad, it's okay. Here they said no, 2 out of 3. Feel the difference. Means either AC, estimated fetal weight less than 10 centile, or crossing centiles more than 2 quartiles. RCPR, Cerebroplacental ratio less than 5th centile, or umbilical artery Doppler more than 95th percentile, right? So we have already actually discussed this thing, crossing the 2 centiles. Means if a patient is coming after or at 32 weeks, her Doppler are normal, but her AC is less than 10 centile, and on follow-up growth scan, it is crossing 2 centiles. We will say this is FGR. Got it? Even with normal Doppler. Because they said 2 out of 3. 1, 2, we have completed. Both don't have Doppler. So after 32 weeks, basically baby still can have FGR even with normal Doppler. Right? Okay, so we can practice it with this question. At 30, primary gravid at 34 weeks, fundal height is static, no uterine anomalies. You have obviously static, so you have requested scan. Now you have scan. Her estimated fetal weight 20th centile, AC second centile. Second centile, we are here. So whatever is, umbilical artery normal or abnormal doesn't make any change in definition. Whatever is CPR ratio, if it is normal, even then this is less than 10 centile. Okay, so what we will say, this is late FGR, right? Okay. Now, yes, let me to complete this slide. You will get your query. But if you have any query, please note it down somewhere. I will definitely answer all your queries. But right now, I'm in a rhythm. If you will stop me here, then I will forget to add so many important information. So it will be at the end your loss. Okay. Okay. So here patient is at 36 weeks and there are no fetal anomalies. Ultrasound says estimated fetal weight is less than 8 centile, AC less than 7 centile. Growth has crossed more than 2 centiles. Doppler normal. So it is more than 3rd centile. It is less than 10 centile. So by definition, this is SGA if we are checking this patient before 32 weeks. But at 32 weeks, because 2 out of 3 features has been, positive. So this is still late FGR. Now I think you can better understand this late FGR definition. Okay, so far we are just working on the recipe and ingredients. We have not yet started the guideline, but trust me, without reading the guideline, you are able to understand the whole guideline if you know well about the ingredients. So important thing was we noticed that like there is a difference between SGA and FGR. Then we type FGR into 1 and 2 and early and late, and about the causes, about the test which we should do with type 1 and type 2, symmetrical, asymmetrical, brain sparing. And then we divided into early onset, late onset. And then we have noticed the difference as well. Then they are not the same. If patient is coming at 32 weeks, definition is changed. So what about the twin pregnancies? So far, we have actually covered only single pregnancies, SGR. Now, with this, we will complete twin. I know this is a different Green-top guideline, but I used to do similar things together. This is my own style. Apology for this. So just imagine a patient is having monochronic twin pregnancy, because in dichronic twin, nothing is different. This is just like single twin pregnancy. Singleton pregnancy if patient is having dichronic twin. Because like single, dichronic twin have their own placenta. But in monochronic twin, there is a difference. We used to say in monochronic twin pregnancy, select that we used a term which is SGA. What is SGA? SGA. This is not as small for gestational. This is selective growth restriction. If we are seeing SGA in single, this is SGA. This is not FGR. But in twin, if we are using this term where S is small and GA is big, so it means this is selective growth restriction. This is just like FGR. So be careful. Dealing twin is different. And apparently looking terminology is also different. So this guideline says a patient who is having twin pregnancies and single placenta, how we will define selective growth restriction. We will, we are familiar with this. Estimated fetal growth of any fetus is below the 3rd centile. So this is selective growth restriction, means only one baby is growth restricted. Or 2 out of 3 following, means estimated fetal weight discordance is more than 25%. Smaller twin, estimated fetal weight or abdominal circumference is below the 10 centile. 2 out of 3 criteria. One this, or with abnormal Doppler, right? So you will appreciate in twin, the definition and abbreviation is slightly different. If one baby is AGA and if one baby is SGA, right? So we will use the term of selective growth restriction. And how we will say this baby is not SGA, rather FGR, right? We will check the criteria, and it is the same. Like growth is less than third centile. This is not SGA. This is FGR, like single. Or 2 of 3 criteria. One, growth difference more than 25%. GTG says more than 25%, and NICE says more than 20%. GTG is latest, so follow this difference. And second one, growth difference is less than 10 centile. So these two are actually they are 3, 1, 2, 3. So in these 3, 2 must be fulfilled if we want to label it is growth restriction or FGR, right? This is about twin. Got it? Okay. So moving forward, sometime you will see in your practice books, you have to calculate the data. They will give you twin A having 1600 gram weight, twin B is having 1200. So how you will check if the difference is 25%? You will actually be, minus it. Bigger twin weight, you will minus the smaller twin weight, and then you will divide it from the bigger twin weight, and then you will multiply it by percentage. This is simple math formula. And if the difference is more than 25%, it's mean the baby is at risk of FGR. If with this, any two is criteria is meeting. Or straightforward, this if any twin is having straightforward less than third centile, no need of 2 criteria. This is straightforward FGR. But if this is if it is less than 10th and more than third, then you should check the difference as well. Got it? Then you should check the Doppler as well. Okay. So important screening threshold, if estimated fetal weight discordance is more than 20%, according to the NICE, and a smaller fetus has estimated fetal weight or abdominal circumference below 10 centile, this is associated with increased perinatal risk and should trigger at least weekly ultrasound surveillance. You have to remember this, weekly ultrasound surveillance. We will revise it in twin as well, but if you are doing single FGR, then in comparison, you must do twin FGR monitoring as well. At the end of this session, I will cover you the type of twin FGR type 1, 2, 3 definition, how you will monitor them, and when you will deliver them, and what will be the mode of delivery. So just leave this thing here. We will come back and we will revise it. So far we just discussed the definition of FGR and SGA in single and twin, right? Now coming towards our decision-making ingredient, this is Doppler. I will take time here if you people have time. If you people don't have time, I will just skip the slide. कितना टाइम कितने घंटे लिखने टुको अंकल से फ्रेंड बुला लो जो करना है करो. So let me know what you want. You want me that I should prove this technique. Oh. Yeah. So, what kind of Doppler is this? This is, you can see notch. So, can you see my echo is coming up in background? Can you notice? Chat, please let me know in chat box because I am hearing my own voice. So, okay. Let me to fix it. So this is still echo is there. Still echo is there. Okay, I will try. Echo. आने तो नहीं चाहिए. Do one thing. Okay. Yes, we were at Doppler interpretation, and before this we start Doppler. Let me to actually revise you people. There are various type of Doppler. The most important Doppler is umbilical artery Doppler. Umbilical artery Doppler, right? And this is the only primary surveillance tool. It will decide if you want to do any additional Doppler, right? Okay, so there are add-on Doppler as well. Earlier we noticed that it was uterine artery Doppler. Uterine artery Doppler function was that it was helpful only in high risk conditions, so that we can do it between 18 and 24 weeks, and we can plan when to start intervention in high risk cases. Till that point, there was role of uterine artery Doppler. After 24 weeks, there is no role of uterine artery Doppler. And uterine artery Doppler will give us three outcomes. It can be normal. It can be abnormal. Abnormal mean either you will see notch or you will see PI more than 95th centile, right? And if it is abnormal, we decided we will start earlier intervention, we will start regular growth scan and Doppler in high risk cases so that we can pick FGR earlier, right? And we can take decision of delivery or additional monitoring earlier, and we can give more benefits to that patient which is already having high risk conditions, right? So that was one additional Doppler. Second additional Doppler is ductus venosus. Ductus venosus role is it is used after umbilical artery Doppler and not in every conditions. When umbilical artery Doppler, let's say it is UAD, is absent or reverse. So if umbilical artery Doppler is absent or it is reverse, and it is early onset FGR, then there is a role of ductus venosus. And what additional benefit this additional Doppler will give us? On the base of this additional Doppler, we can plan time of delivery. Time of delivery, right? So we will add that. Let's assume a patient is coming at 27 weeks and her Doppler is absent or reverse. And we know that in preterm fetuses, they are more prone to adopt. They can stay or survive longer as compared to late FGR. So if we will add ductus venosus here with absent and reverse umbilical artery Doppler ultrasound situation, we can plan time of delivery. Like if umbilical, if we have ductus venosus and it's normal, so we can take this pregnancy till 32 weeks easily with this monitoring, because ductus venosus is normal. Whether in the background our primary tool was showing that the Doppler is absent or reverse, this is, the baby is at risk of, complications. But we are facing two things. If we will deliver right now at 27 weeks, baby is having small placenta, FGR condition, and also prematurity. So prematurity is also a bad thing. So to negotiate this situation well, ductus venosus will give us, fair area to play. If it is, if really it is going to be perinatal complications, then ductus venosus will be abnormal, and then we will deliver that baby. We will not wait to bring that baby till 32. We will deliver maybe that baby till 29 weeks, right? So this is the benefit of ductus venosus. Now, what is an additional type of another Doppler? And this is MCA. MCA has various roles. MCA help us in brain sparing picture. It will give us brain sparing picture that baby is yet actually coping up, because if baby is showing brain sparing effect, it's mean baby is able to fight. If no brain sparing, then baby is not able to fight. So one benefit of MCA is that we can see brain sparing effect. And before 37 weeks and after 32 weeks, its role is just like supportive. It will just help us that we should plan more frequent monitoring. It's not decision making, please. Ductus venosus was decision making before 32 weeks and after 26 weeks. But MCA is not decision making after 32 weeks and before 37 weeks. Yet we will do MCA, obviously. And its important is only that it will guide us that how frequently or how individualized we can run more additional investigations. That's it. But third role of MCA is decision making, and it is after 37 weeks. Clear? We have discussed uterine artery Doppler, we have discussed ductus venosus Doppler, we have discussed MCA so far. Clear? Okay. So MCA role, it will give us brain sparing picture. It will guide us about additional monitoring before 37 and after 32, because after 32 there is no role of ductus venosus. And after 37, third role is that it will guide us about the time of delivery. Okay, so that was overview. Now we will run the slides quickly. This is a picture showing that uterine artery. First problem will be in the uterine artery. if uterine artery is giving less blood, then obviously the result or consequences we will later see in the umbilical artery. So early picture uterine artery will give. That's why we will do uterine artery earlier, before 24 weeks, and after 24 weeks we will do umbilical artery. Okay. What happened in pathophysiology? First we see decreased diastolic flow. Decreased diastolic flow means increased pulsatility index. It is earliest sign of placental resistance, but it's mean that still we have time. With good monitoring, we can bring pregnancy till 37 weeks. First, every pathology has some, timeline, some natural history. Some, like just imagine the cancer, stage 1, then stage 2, then stage 4, 3 and 4. It is not like that directly a patient will develop stage 4. No, you have not picked stage 1, 2 and 3, but the cancer has actually run all these stages. Similarly, if you are looking pregnant woman and baby and her placenta is showing resistance, reverse flow, it doesn't mean it happened overnight. It's mean earlier it was decreased diastolic flow, then it will become absent, then it become reverse. So earliest sign of placental resistance is increased pulsatility index or decreased diastolic flow. Right? Decreased diastolic flow in umbilical artery is bad. And decreased diastolic flow in MCA is good. They are opposite to each other. And here comes your exam question. Got it? If diastolic flow decrease in umbilical artery, this is bad. And in MCA, if decrease, then this is good. So the same picture in umbilical artery is bad, and in umbilical artery is good. Here they go opposite. Okay, so then coming towards absent. Absent means it indicates fetal compromise. Decreased shows fetal placental resistance. Absent shows fetal compromise, and reverse shows severe placental insufficiency. We can divide them in actually borderline. We can divide Dopplers, umbilical artery Doppler, ductus venosus, both. Borderline if PI is more. Pre-terminal if absent. Absent in umbilical artery and absent A wave in ductus venosus. This is pre-terminal sign. And terminal sign means, anytime can that happen, is when reverse A wave in ductus venosus or reverse diastolic flow in umbilical artery. So far clear? I'm going very slow. Apology for this. I am taking a lot of time because I believe if you will fix FGR right now, then you will actually make good choices in your clinical scenarios, in your exam, whether it is theory or it is talks or even, in real time. We started from 40 members and we left with 20 members. This is height of your interest. If you people are not interested, we can actually quickly run the slides as well. I'm not actually bound to, go very, very deep. I will just, open your boring Green-top guideline like every other before the lecture, I have actually scroll every FGR lecture on YouTube available, every course provider, and they started from the Green-top Guideline. And actually, I myself lost. I was not picking up anything. Then I thought it is difficult for me. Then how difficult it will be for my students? Then I thought, no, it will not run like that. I have to actually work from very beginning. Interested. Okay. So, if you want me to stay interested, I want to actually see a lot of emojis in chat box. Okay? Okay. So, yes, here we are. If it is borderline, if PI is more, thank you. If PI is more, then it is borderline. If absent, whether it is umbilical artery absent or ductus venosus wave absent, both. Just remember word absent. This is pre-terminal. And if reverse, whether a wave in ductus venosus or umbilical artery flow, this is terminal. Terminal means you have to do daily monitoring, daily CTG, daily Doppler. And pre-terminal conditions mean you have to do on every alternative day. Doppler and CTGs. And borderline means you have to do weekly Doppler. One question for sure is coming up from this, because the table which they have added in their GTG is very confusing. You can't pick better key with that. That's why I'm not showing that guideline. Not a single page so far I have shown of that guideline, right? So remember, borderline, weekly, pre-terminal means alternate day, monitoring, terminal means daily. Clear? You will not forget it now. Okay. Okay, so moving towards next slide. Now I will just run the slides. I will request you people just remember the formulas. Please, you can see them, although rare, but you can see them in exam with the definitions. What is RI, what is PI, what is ST. Okay? So resistivity index and pulsatility index, we are more interested in PI for our scenarios. So focus on PI more. PI is mean PSV, peak systolic velocity minus diastolic velocity. Let's assume we are discussing PI of umbilical artery. So how we will calculate PI? We will use peak systolic velocity, then we will minus diastolic velocity from this, and then we will divide it from mean velocity, right? Peak systolic, diastolic, then mean. If you want to skip, you can skip as well. There's very rare chance that they will ask about PI formula and SD formula. But if you want to do only one, then do the PI formula at least. And this is MCA, actually history. I told you already that what happens. Fetus brain does not need maximum blood flow, which means there is high resistance in MCA. This is normal, please. I told you people, if resistance is high in umbilical artery, this is bad. And opposite to that, if resistance is high in MCA, this is good, because fetus brain does not need maximum blood flow. This is your baseline concept. If you know this, then you will never mess the interpretation of MCA and umbilical artery Doppler, because apparently they will look like same, but their concept is opposite to each other. So what happened in MCA? Normally, resistance is high. So normally cerebral vessels stay vasoconstricted. Blood flow is mainly during systole. Diastolic flow is low and PI is usually high. This is normal MCA. However, if hypoxia, whether in rhesus situations or anemia in FGR, fetus wants the maximum to protect brain, so it will vasodilate. In struggle, it will vasodilate. So in this struggle, you will see PI is going to reduce. And this decrease in pulsatility index in middle cerebral artery is giving you a picture of brain sparing. Trust me, you cannot otherwise understand what is brain sparing. You will see OSCE scenario. They will give you a lot of information and they will give you at 32-week MCA. And they will say PIs, PIs decrease. So you will be happy. This is good. No, in MCA PI, if decrease is not good thing. This is good thing only in umbilical artery. If it is decreasing, it's mean baby is coping up. The baby is brain is showing sparing effect. Clear? So just remember certain values. If we divide PI of MCA with PI of umbilical artery Doppler, this will actually give us picture of what is actual cerebral placental ratio. If it is more than 1, this is good. Right? Vasodilatation in MC occurs only during hypoxia. It's not normal picture. Its mean PI is low. This is the baby is showing brain sparing effect. Got it? This is for sure coming up in your OSCE as well. There was in Lahore, there was a station in MRCOG 3 as well. 2 days back, 3 days back, there was online exam was in Lahore, and it was their 4th station, and at 32 weeks, they provided MCA with PI less, and the majority was happy that this is good thing, because at the same time, they said CTG was okay. CTG was okay, and pulsatility index of uterine artery Doppler was more than 95. And obviously they have given a lot of data STV as well, we will think. And examiner was one by one asking the candidates, interpret this, interpret STV, interpret CTG, interpret growth scan, interpret symphyseal frontal height, interpret PI, what is definition, everything. So if you, and in the recent FCPS exam, and today was second day of exam, and next 2 days we will see SGR, growth scans, Doppler. They are routine stations now. Okay. Okay, so I already told you people, if borderline, then raised PI, right? And you have to monitor weekly. If absent, then it is pre-critical phase. Then you have to monitor alternative day. What you have to monitor alternative day? Doppler and CTG, not a growth scan. Growth scan minimum time is 2 weeks. Before this, you cannot differentiate the difference because that is too slow to pick, too low to pick for routine machines. And critical means reverse. And here you will go for daily ductus venosus and daily CTG. Daily or continuous, any. Again, borderline, umbilical artery PI above 95th, ductus venosus PI above 95th, this is borderline. Weekly, you have to repeat Doppler ultrasound, right, with CTGs. Pre-critical, absent and diastolic flow in umbilical artery are absent A wave to baseline in ductus venosus. It's pre-critical, so alternate daily means one day you will skip and then another day. And critical means daily computerized CTG, daily ductus venosus. Reason, because this is sudden fetal deterioration. In reverse, there is, this is a decompensation phase. PI, if increase, this is compensatory phase. MCA, if it is low, this is compensatory phase. Baby is actually compromised but compensating and showing brain sparing. But when it is reverse, this is frank decompensation, critical. You have to plan delivery. So how they will look? There are three types of Doppler. One showing normal ST, this showing increased PI or increased SD ratio, this showing reverse. Absent is missing in it. Here it is absent, right? See, is this is normal. This gap is reduced, right? This is decreased, but yet positive diastolic flow. Here diastolic flow is totally absent, touching the baseline, and here it become reverse. If you will understand the difference, then you can take an exam as well. Then this is normal, here it is slightly low, so it means diastolic flow present, but PI is more. And if it is umbilical artery PI, this is bad thing. And if MCA, then it is good thing. Then absent, and then reverse. Okay. Now uterine arterial Doppler showing bilateral notches. Here you can see notches, and they will give you a picture like patient is at 21 weeks having chronic hypertension and previous preeclampsia, and what you will do next. You will obviously say, I will go for uterine arterial Doppler. What you will see? I will see notch and increased resistance. What happen if it is there? Then I will plan early intervention from 26 weeks. I will advise her to actually repeat her Doppler and serial scan, right? Okay, so just skip it. Next, this is very important. Umbilical artery Doppler notching RPI more than 95th. This is abnormal, right? Uterine artery Doppler notching are more than 90. Notching you will not see in umbilical artery. You will only see it in uterine artery. Okay, so umbilical artery will show you certain type of abnormalities, increased PI, abnormal RI, increased SD ratio, or and diastolic flow absent here reverse. MCA will give you reduce PI. Reduce PI is bad thing because vasodilation is always bad. It means baby is trying to compensate, brain sparing. And middle cerebral artery peak systolic velocity we use to quantify the anemia. PI we use for brain sparing, and PSV we use to quantify the anemia. Be careful. You will see various options. Means you want to check brain sparing, and they will say you how you will check MCA PI or MCA PSV, and then you will just be oh my god, I just know this was MCA. I don't know what next, PI or PSV. So take your limits till PI or PSV. In anemia, in transfusion, in parvo, in RH negative, they will give you PSV. In FGR, they will give you PI. Be careful. Okay. So case number 2. This is absent and diastolic flow. A patient, let's assume, comes at 31 weeks, growth scan showing estimated fetal weight less than third centile, like also less, Doppler pulse rate index above 95th. And the basic thing is absent diastolic flow. So it's mean this is pre-critical phase. Alternative daily, you have to repeat her CTG and Doppler. And then this is MCA, right? MCA. Okay. So MCA and CPR. For CPR, you have to check 2 Doppler. One umbilical artery Doppler and second MCA. And if you will divide them, then it will be cerebroplacental ratio. If it is less than fifth centile, it's mean it will determine the frequency of the surveillance, right? Before 37 weeks, if MCA is bad, you will just comment on how frequently you should check, you should do monitoring. You cannot decide time of delivery. Time of delivery on the base of MCA, you can only decide after 37 weeks. Please be careful. With hypoxia, there is reduced resistance and increased diastolic flow, means decreased PI. So, reduced PI in MCA and increased PI in umbilical artery will provide us cerebroplacental ratio. If it is more than 1, it is good. If it is less than 1, this is bad. Normal MCI is more than 5th percentile. If it is less than 5th percentile, this is bad. So remember this. Normal is more than 5th, and if it is less than 5th, it's mean brain sparing is positive. This was your OSCE station. And candidates who appreciate it, they get good marks, definitely. And many were saying, ma'am, actually we forget what was how to interpret. We are actually saying it was 95th, like just like umbilical artery. No, it's 5th for MCA for brain sparing. If it is more than 5th, good. Less than 5th, bad. So CPR remember with 1. Got it? So far, any confusion in CPR, in umbilical artery? Okay. Just imagine 34 weeks, CPR is reduced, MCA is reduced. It's mean brain sparing. You have to do more frequent monitoring, but time of delivery, you can't decide on it. For time of delivery, umbilical artery is decision making. And short-term variability is decision making. Growth velocity, if static, is decision making. Right? Okay. This is reverse diastolic flow. So just again repeat, ductus venosus is used in preterm fetal growth restriction, especially before 32, where umbilical artery Doppler shows absent or reverse. So indication of asking ductus venosus is not routine early FGR, only those FGR in which umbilical artery Doppler is absent or reverse. And in absent, you will consider, and in reverse, you will offer. This is also very important. So delivery trigger depend on, I told you in preterm ductus venosus is delivery trigger, and in term after 37 weeks, MCA is delivery trigger, right? In preterm fetal growth restriction with umbilical artery absent or reverse, before 32 weeks, delivery is recommended when ductus venosus Doppler becomes abnormal or umbilical venous pulsations appear. So umbilical artery gives us placenta problem. Ductus venosus show us fetal heart rate compensation. This is the late sign. If it is bad, it's mean no, anytime IUFD can happen. I will show you in next slide what does it mean by abnormal ductus venosus, how you will interpret A wave. No worries, it's very easy. Okay, so when umbilical artery Doppler become absent, reverse, you will check ductus venosus, and you will check about, you want to check about the fetal heart rate compensation, not about the placental problem, because placental problem already has been picked by abnormal umbilical artery Doppler, right? So umbilical artery Doppler absent, ductus venosus, you will go. But if it is reverse, you will strongly order ductus venosus. It's mean only on reverse and diastolic flow before 30 weeks. You cannot take the decision of delivery. You have to see the ductus venosus as well. Preterm fetus less than 32 weeks with absent reverse ductus venosus. So Ductus venosus, we have S, D, and A wave. And positive flow in A wave means normal arterial pressure, means normal fetal heart rate. In compromise, it goes from positive. First, it will be positive, then it will be absent, then it will be reverse. Reverse means fetal acidemia. Used in preterm fetus when umbilical artery Doppler is abnormal in severe FGR. And it helps in deciding the delivery time. Okay, so just leave it there. Okay, just leave it there. First, I want to, yes, see. So follow my, this is normal ductus venosus. This is normal S wave, this is D wave, and this is normal A wave. We are only focused on A wave. Forget about S and D. They are not decision making. So here, just imagine this is a baseline and this is positive A wave. Here, it is slightly reduced, but still present. So we will just see A wave in ductus venosus. Here normal, here reduce, just like umbilical artery, and here absent, touching the baseline, and here it crossed the baseline, means reverse. Now tell me, this baby is critical, pre-terminal, or borderline? Write in chat box. Baby, umbilical artery Doppler reverse, and ductus venosus A wave reverse. This is critical. So what next? You will go for daily Doppler and daily umbilical artery with CTG after admission, or alternate day, or weekly. So terminal means daily. Yes, Tana. And obviously, if the baby is at 29 weeks with reverse diastolic flow in umbilical artery and reverse A wave too, will you prolong it? No. You will give her steroid, amaxalfate, and after 48 hours, if CTG remains good, you will deliver as elective section. Otherwise, you will do emergency section if CTG is bad. So, just remember, if diastolic flow is reverse or A wave in ductus venosus is reverse, it doesn't mean emergency section. If you have time, if CTG is still good, you must have to give her steroid. Please, they will give you this in scenario and you will go for emergency section. No, give steroid, give maxalfate, right? Wait for 48 hours with continuous CTG and then do elective section. Clear? And if CTG is bad, then no steroid. Then no steroid. If the same patient comes with reduced fetal movements with bad CTG, no steroid. Pathological CTG, go for section, emergency section. Basically, you will pick section. I know. The real dilemma will be when they will give you choice of after steroid, maxalfate, elective section, or emergency section. Here you will see what I should do. It is reverse. It is, baby is having metabolic steatosis. This is emergency section and category 1. And category 1. Don't do this. This is not emergency section. Early delivery is planned, but still after steroid cover. If as CTG they have not given, it's mean this is okay. If they are showing you CTG and it is bad, then obviously then emergency section and category 1 section if pathological CTG. No, pathological CTG category 1. Suspicious CTG category 2, but this information applicable if patient is in labor. NICE does not comment on antenatal CTG. But Irish comment, I will cover it in CTG, no worries. Okay. So here this is, and don't worry, if you see Doppler is showing ASD, it's mean this is ductus venosus. Sometimes it become difficult to identify this is ductus venosus or umbilical artery because every Doppler looks like same. So with brain, if they are focusing, then it is MCA. If they are focusing umbilical cord area, then this is this can be ductus venosus. This can be umbilical artery. But if they are showing ASD waves, then definitely it is ductus venosus. This is a smart tip. So 28-year-old patient, 30 weeks, umbilical artery shows reverse and diastolic flow. Obviously, this strong indication for ductus venosus, and here you see absent A wave. Absent A wave means baby is in pre-terminal phase, right? Okay. Now about the short-term variation. Short-term variation means this is STV. It tells us how much the fetal heart rate changes from one beat to the next. A healthy fetus has normal autonomic nervous system activity, so the heart rate shows small beat to beat, variation. Why small? This STV is important because it gives us idea about FGR, preterm fetal surveillance, abnormal Doppler cases, and suspected fetal compromise. Low short-term variations on computerized CTG suggest the fetus may be becoming hypoxic or acidotic. Here I will give you a tip. CTG, which we do in labor room, is different. We can interpret it manually with naked eye. But computerized CTG automatically detect short-term variations. We can't pick without computerized CTG or without computerized help, right? And it's computer work. They will give you STV 2, 3, 4, 4.5, whatever. And if the routine CTG is bad, this is indication of emergency section. But if routine CTG is not bad, only short-term variation is bad, it's mean this is not that much urgent. Still, you can actually take time to in pre-op, in theater preparation, first dose of steroid. So nature of emergency, actually again follow the timeline. What will happen first? Computerized CTG will become abnormal, and then the routine labor room manual CTG will become abnormal. So this is stage 1 cancer, and this is stage 4 cancer. So stage 4 cancer is just like emergency. We will take emergency decision, and this is stage 1, so we can buy good time in planning. Clear? Difference in STV and routine CTGs. Okay. And if this concept is clear, only then you can actually process the information, which I will show after this theory class in your talks slide. I have attached that talk slide as well, the recent OSCE exam station, and the decision making was STV, and that was not that much urgency. Many have done STVs very slow, so they will, they planned a crash section. That was their mistake. Okay. So remember, from 26 weeks onward, deliver if any red flag appear. What red flag? This red flag. Number 1. Before 26 weeks, if STV is bad, we can't do anything. This is, individualized management. However, after 26 plus 0 till 28, deliver if ductus venosus A wave is absent or reverse. One indication or STV is less than 2.6. Means you are following a case in which patient is already having high risk abnormal uterine artery Doppler, and then you checked her umbilical artery later at 26 weeks, and it is showing reverse flow. And because it is reverse flow, it is strong indication of ductus venosus. Ductus venosus also showing that a wave is absent. So this mean you can plan delivery here as well, right? And if let's assume ductus venosus is okay, but short-term variation is less than 2.6. This is also independent indication to deliver at, between 26 and 28. You have to deliver this baby whose baby is showing STV less than 2.6 between 26 and 28 plus 6. Okay. The STV basically rise or become higher with gestational age. At 26, it is also 26, 2.6. But after 28 plus 6 or before 32, its value is 3. Means it is slightly increasing. Earlier it was 2.6, then it is 3. So when we will deliver, if gestational age is between 28 and 32 and this STV is less than 3, then this is indication of delivery. Not urgent, but like any time between 29 plus 31 plus 6 weeks, we have to deliver this baby. We can't prolong it, even with, reverse diastolic flow. We know reverse diastolic flow, we have time till 32. We can consider till 32, but that reverse flow, which is having STV less than 3, we can't prolong it till 32. We will deliver 29 or, between 31 plus 6. And earliest time is 29. We will give steroid, maxilfate, discuss, refer to. And remember, whenever such a situation, always plan such deliveries in those centers where neonatal services are inside the hospital. Right? Okay. Now baby has crossed 32. Between 32 or you can say 34. And because 32 has been crossed, there is no need to, go for ductus venosus. Here, our Doppler will change. Here again, umbilical artery will be the decision making without ductus venosus. Because ductus venosus rule was till before 32 in early preterm, in early FGR. So that the moment gestational age touches 32, the Doppler also change. Then it will be the umbilical artery Doppler. If it is, showing reverse, then we will deliver obviously at 32. The reverse maximum time was this. Or STV is less than 3.5. We will deliver. And onward 34, STV will be 4.5. See, earlier it was 2.6. Earlier, just focus on STV, right? 26, 28, STV 2.6. Then 28 till 32, STV 3. Then 32 till 34. आप इसको ऐसे कर लो before 34. STV 3.5. Then 34. STV 4. Got it? 2.6, 3, 3.5 and 4. With gestational age, STV is rising. This is the pattern. So it's mean whatever is ductus venosus, alone STV is decision maker to decide the time of delivery. Earlier in preterm FGR, only ductus venosus was, in preterm, ductus venosus was decision making. But STV is decision making in preterm and also in late term, because we are, going till 34. So this is the role of STV. STV is stage 1, and first STV will be bad, then the routine CTG which we do intermittently in our labor room will become bad. Definitely. So we will not wait that time. We will plan before this. We will give steroid cover and maxilfate timely. Got it? So 21, 26, 31 ductus venosus, 32 no need of ductus venosus because 32 means no preterm, right? This is late FGR. No early FGR. This is late FGR. Ductus venosus role is for early FGR. So now independently correlate STV and Dopplers, right? So we have checked the cutoff where we should deliver 2.63, 3.5, and 4. But if roughly, if umbilical artery absent, maximum time is 34 weeks. And if it is reverse, maximum time is 32 weeks. Clear? Means 30 to 32, and here 32 to 34. This was same as it was in previous guideline. So far it is clear? STV clear? Okay. If still you have interest and you're understanding, this is good thing, because I was afraid you maybe lose interest and maybe you will not understand many things, but it is good. I am able to deliver you the concepts even with my poor English. Okay. Actually, we have one Bangladeshi student and one Indian student as well, and they can't understand English. They requested me, ma'am, please take detailed theory lecture on it, and then because of them, I am speaking in English. Okay. मैम को क्या हो गया इंग्लिश बोल रही okay. So remember, do not forget 26, 28, 2.6, 29, 31, 3, 32, 33, 3.5, 34, 4.5. You know, in the recent OSCE station, the value was, the patient was at 32 weeks and her STV was 3.2. Her STV was 3.2, her PI was 95th. So if PI is 95th, means ST ratio increase and diastolic flow present, we deliver at 37 week, right? But they have given STV 3.2. Can we deliver at 37? No. We maximum has time till 33. And in this time, we just have to, fulfill the protocol of maxilfate and steroid, and that's it. And we have to deliver. So this was quite different scenario. It never came in exam. This is first time I see such interesting OSCE station, which was only, in which the STV was decision making, because we have concepts only like absent reverse and, absent 34, reverse 32, SD ratio increase 37, right? But this thing has changed the scenario as well. I know, I think examiner now are very, very clever. They know we are not reading STV. Okay, so remember, if absent A wave inductor stenosis and absent diastolic flow in umbilical artery, we can deliver any time between 26, 33.6. This is our time. In absent, we can deliver 26 till. This is the maximum time because I have not given you the STV, right? Just focus here. Okay. And now absent in umbilical artery. So absent in umbilical artery, then we can consider at 32 and absolutely before 34 week. Reverse, we can consider at 30 and absolutely before 32. PI more, we will deliver maximum 36 till 36 plus 6 before 37. This is very important table by time of delivery because it has been revised now. Earlier it was not like that. Estimated fetal weight less than third centile, but Doppler is normal. means like this is FGR with normal Doppler. Here you will deliver 37 plus 6. Have you noticed the difference? If Doppler is abnormal, you are delivering before 37, means 36 plus 6 in FGR. But that FGR where Doppler is normal, you are, delivering 37 plus 6. You have registered that difference? Have you registered that? Both are FGR. This is FGR, this is FGR, this FGR we are delivering before 37. This FGR we are delivering after 37. When you will read, yourself, you will stay here and your mind say, what's going on? And you will lose altogether interest and you will say, no, I can't read this guideline. Don't do this. This is very simple. Clear? Here, both are FGR, one with only severe growth restriction and one with abnormal Doppler. Now only SGA. No severe growth restriction, no growth, no Doppler problem. Here we will deliver at 39 plus 6 days, 39 plus 6 weeks, you can say. So SGA we will deliver by NVD. Doppler normal, although growth restriction is less than 7, but still we will deliver by NVD. PI more than 95th, or MCA is less than 7th, whatever. But yes, still we can do NVD. We'll do only section if Doppler is absent or reverse in umbilical artery or in ductus venosus. Or there are bad STVs or bad CTGs. Or placenta previa previous to. But they say if Doppler is abnormal, baby is already growth restricted, there are more chances of emergency section in SGA, in FGR. But so far, if diastolic flow is present, not absent, not reverse, your plan of delivery will be, you will discuss with patient and you will fairly discuss her chances of emergency section. And if she opted, then you will offer her normal delivery and you can induce her as well. But preferably you will induce her with mechanical methods because prostaglandins will add hyperstimulation, baby is already compromised. Got it? So this slide is really very important. How to deliver, when to deliver, and when to induce, and which method you should use. This is only summary of the slides which we have discussed so far. Summary of slides. Summary. Now you can understand these boring tables. Okay, when patient comes at booking, you will assess her risk. No risk, nothing. No Doppler, no serial growth scan, only serial fundal height like every other patient. And one serial height should be done after 28 weeks, that's it. If it is moderate risk factor, means you will start serial growth scan from 32 weeks and 4 weekly because this is on risk factor based assessment. Okay, whatever is her risk, always reassess patient at 28 weeks after any antenatal admission because new things can happen. Assess for complications developing in pregnancy later, like later she can develop hypertensive disorders at 32, 32, 34. If any new complication, then manage as per that recommendation. Like hypertension guideline says when hypertension, go for serial ultrasound, right? Now, the baby is high risk. And if the baby is high risk, we will do uterine artery Doppler. If uterine Doppler is normal, then 32, 2 to 4 weekly, maximum 4 weekly, but as it is high risk, the minimum can be 2. Just a minute. Hello? Hello? जी ओके मैं आ रही हूँ जी बेटा, मैं आ रही हूँ, मैं आ रही हूँ, मैं आ रही हूँ। सॉरी भाई, मैं अभी मेरे बच्चे लॉक हो गए हैं। आई एम जस्ट कमिंग 1 मिनट नाउ। Okay, so where we were at high risk conditions. We already know what are the high risk conditions, and because many of them overlap with aspirin as well. So, in high risk conditions, we know they are high risk FGR is also at risk of having preeclampsia. So, if we will give Loprin, it will reduce FGR as well and preeclampsia as well. But our intention is very important. If our intention is FGR prevention, then we will give 150 milligram before 16 weeks, right? Specifically previous hypertensive disease, previous FGR, before third centile, right? And any delivery of any SGA because of placental disease before 34 weeks. In all these conditions, we will give Loprin before 16 weeks and we till 36, till 36. But if our intention is prevention of preeclampsia, then it is not like 36. Then we will give till delivery. Okay? Okay. So, yes, I will discuss this Loprin difference in coming up slide. Today is day where we will discuss cover all our doubts, no worries. There is a slight difference between Loprin dose, indication, and timeline. If our intention is prevention of FGR or prevention of preeclampsia, please be mindful. Okay, as it is high risk, so uterine artery Doppler is good, normal. Then routine ultrasound, serial ultrasound, not a growth scan. But if it is abnormal, then we will start, intervention from earlier, 26, 28 with Doppler and serial scan. There are slight difference, like if uterine artery Doppler and estimated fetal weight, uterine artery Doppler normal, but baby is having SGA. Even then, we will not take it like 32. We will start monitoring from 26. This is also important thing because baby is SGA. And here, uterine artery Doppler is abnormal. If anything is positive, like Doppler abnormal or growth abnormal, we will start earlier intervention. But slightly more earlier if growth is less, right? Like 26 and here is 28. And if both are abnormal, then definitely we will, earlier intervention with growth scan and Doppler, but we will discuss it with fetal medicine as well. This can be your probable question. Matlab means they will say uterine artery Doppler is abnormal, R notching, RPI more than 95th, and at the same time, AC or estimated fetal weight is also abnormal, means less than 10 centile. So what is this? Doppler bad with SGA. This is FGR likely. So early FGR means it can be chromosomal problems as well. So we have to work, with consultants. So here we will go with fetal medicine and take fetal medicine input as well. Not only will rely on, Doppler and serial growth scans, right? And I already told you fibroids, BMI 35 or more, any uterine anomaly, then fundal height is not reliable, then you have to go for serial ultrasounds. And if estimated fetal weight is more than 10th, this is good, right? But still, as fundal height is not reliable, we will keep our own serial ultrasound from 28 weeks in women with congenital uterine anomalies and 32 weeks in women with other things which are not suitable for fundal height monitoring, like having obesity, right? So if you will do this table earlier, I was sure you will probably miss so many things, but now you can understand what's going on. You can understand the logic behind. And okay, next is this. I will suggest you don't do this, because to avoid this boring and table, we have done already so much effort, right? But they said that early STV, early FGR, late FGR, STVs, we already know 2.63, 3.54. We already know this. Delivery of spontaneous repeated CTGs have problems, maternal indication like preeclampsia, help. It can happen with FGR as well. Both can combine, right? Okay. So now we are going to start some practice questions. You will answer it, and I am sure you can answer now better. SGA less than third centile, normal Doppler. She had same findings again actually she was having same findings at 20 weeks, but she was never investigated. She was missed. And the same patient comes after, later at 29. So what is your management? What is diagnosis basically? At 20 weeks, she was having severe growth restriction. So chromosomal problems, which we missed, but still it doesn't mean they will not happen if she is coming late. Still it is amniocentesis, right? Yes. Okay. Next, 28-year-old patient, primary gravida with a cocaine user intermediate risk. Came at 28 weeks, period of gestation. What is the ultrasound surveillance to be advised? Intermediate risk, how you will plan her monitoring? You can go with elimination as well. C. So it is F. Why C? She is a primary cocaine user. Ultrasound surveillance advice. 4-month ultrasound today for growth by umbilical artery, and 6-month by umbilical artery for growth. Ultrasound today for growth and umbilical artery by umbilical artery in intermediate. Weekly ultrasound bi-weekly, monthly bi-monthly. Ultrasound today and then 4 weekly. It makes some sense. Actually, it should be from 32 onward, but even then we can eliminate and we can, find a less wrong key. This is F. Why C? In intermediate risk factors, we don't do Doppler. We do only growth scan. She is having drugs, that's it. So just see here. Drug misuse. Assess for history of placental dysfunction and consider prescribing aspirin if there was an indication of aspirin, which you already know. Otherwise, anomaly scan and a estimated fetal weight is more than 10th. Serial ultrasound only from 32 and then 4 weekly. Now she's at 28 weeks. At the time of diagnosis, obviously, she is now, see, her ultrasound still has not been done. So one baseline ultrasound we will do right now. Ultrasound today, they have not said growth scan. She is at 28 and growth scan will be at 32 after 4 weeks. Then it will be at 32. It's perfectly ideal key. It's not eliminated key. At the time of diagnosis, 2, you will check her baseline biometry so that you can compare growth potential. Clear? Okay. 41, smoker, 16 weeks, regarding her chance of having a small baby, as her friend recently delivered a very small baby, what you will do? Basically, she is having intermediate risk factors. Her age 41 and smoker means drugs 2. 2 doesn't mean it will make her high risk. She can have 3 or more risk factors from intermediate category. She will still be intermediate. It's not like VT scoring we will add and she will become high risk. So reassure, no. Uterine artery Doppler at no. Serial assessment of umbilical artery Doppler and growth scan from 32. Serial assessment of growth scan. So she need only growth scan from 32 and one baseline today. That's it. So option will be E. Here they have deliberated given us Doppler. And everyone will pick Doppler. Jitna good utna mitha. This is not like that. Doppler you will only add if your uterine artery Doppler is bad. Or estimated fetal weight is bad. Or both are bad. Okay. Next. 32. Again 35 weeks first pregnancy. Reduced fetal movements. What you will do in reduced fetal movements? First of all, you will take history. This is easy. And if no history, then you will auscultate. Don't jump on CTG. By the way, reduced fetal movements guideline has also been revised. We will do it tomorrow. But that is very simple. Only twin will disturb you and this UTR will disturb you. But twin with me, you will feel very good after doing it with me. Okay, 29-year-old woman at 36 weeks period of gestation with IUFGR, umbilical artery Doppler showing normal, pulsatility index normal, middle cerebral artery. What is the next surveillance of ultrasound that needs to be done for this patient? They said C by C because she's at 36 and she's having intrauterine. She's having late FGR with normal Doppler and normal umbilical artery and middle cerebral artery Doppler. Only FGR means must be having only, 2 features out of 3 or 1 less than third centile. So ideally, what should be the ideal key? Next ultrasound for 4 weeks of growth scan and umbilical artery Doppler. Ultrasound after 8 weeks bad, a fortnightly scan for growth and weekly umbilical artery Doppler. Yes. In FGR, we do weekly. Fortnightly scan for an umbilical artery Doppler. If all is normal, we offer fortnightly scan and delivery by. Just hold on. Let me know about if late FGR with a normal Doppler, how we should do how frequently we should do her Doppler. Twice. It weekly or 2 weekly. Weekly or 2 weekly? He said D. Weekly scan, no. Scan, minimum time of growth scan is 2 week. Minimum time is 2 week. So weekly is bad. Twice weekly for umbilical artery Doppler when Doppler is normal. We do it in absent. Bad. Basically, C is not ideal. It's only key which is actually less bad after eliminating all very wrong keys. So definitely we will do her growth scan after 2 weeks. But umbilical artery Doppler weekly we do when PI is more. PI is borderline. So this does not best fit in here. But this is just eliminated key. Eliminated keys are not ideal key. Yes. Growth scan should be 2 weekly. Minimum distance should be fortnightly or 2 weeks. If we will do it earlier, then ultrasound will not appreciate the difference. Okay. Now they have given IUFD. We will do it with IUFD, no worries. the dose is about how we will, let's assume the baby was having, was FGR and ended into IUFT, how you will terminate. So they are, talking about the doses. So 24 plus 6, 400 microgram buccal sublingual vaginal oral misoprostol every 3 hours. After this 200, and after 28, 25, 50, and our patient is at 26. So 26 means 400 microgram, right? Sorry, 200 microgram. 200 microgram and there is a difference between units, microgram with misoprostol and milligram with mifepristone. Be careful. They will give you mifepristone in microgram and misoprostol in milligram, right? But you can skip this question as well because we have not revised any of this so far. Now, 32-year-old patient presents to the antenatal clinic at 32 weeks of gestation with her first pregnancy. She reports experiencing a reduction in the fetal movements over the past 24 hours. So you will take history and then you will go for auscultation. There is no history, so you will auscultate first. Then you will go on CTG. Don't jump on CTG. First, you have to auscultate. If on auscultation, no fetal heart rate, then ultrasound. If positive, then CTG. So, a woman at 30 weeks presents with reduced fetal movement. CTG is normal. She has risk factors for SGA. Choose the most appropriate option from the list. Yes. You can eliminate. Tell me final key. CTG is normal, but SGA risk factors positive at 30 weeks. So, D. Because SGA risk factors are there, that's why. Ultrasound for growth like and Doppler. Okay. Why we have done maternal blood test for infection? Because 27 weeks maternal infection symptoms are there with reduced fetal movements. That was the biggest clue. We already know monitoring of moderate and high risk. We already know this one. We already know this one as well. This is for just summary, time of delivery and mode of delivery. Now, fetus measure at less than third centile, then anomaly scan earlier was done, and no follow-up scan was done. What is the most appropriate next step? 32 weeks. Okay, this is a constant, basically this is a constant issue. At the time of anomaly scan, she was having less than third centile. Here, she should go for one thing. Let me know. Severe growth restriction at 20 week. If she is not following up and showing up later, what you will do? Again, amniocentesis. They love amniocentesis, by the way. Okay. Now, 30-year-old patient has first trimester screening, CRL 54, NT 1.3, HCG normal, but Papa is low. And low Papa is means in first trimester, low Papa means positive combined test. If combined test is positive, we have to do invasive test. And also later we will, she will be at high risk of FGR. If no anomaly is picked up, even then low Papa is associated with FGR. That's why, like at the timeline is important. At this CRL means this is early pregnancy, right? First trimester. So at first trimester, we will do at 12 weeks. I'm new or CVS? Obviously CVS. And later, if CVS is positive, obviously it will terminate. And if normal, then low papa means it is one of risk factor of high risk FGR as well, high risk SGA as well. We will monitor her from, I will do a anomaly scan and uterine artery Doppler. See, here, papa low, less than 5th percentile. Okay, so it's mean if patient is having low papa at first trimester screening, we will do at that time invasive test. And if invasive tests show baby is not having any aneuploidy, then later we will plan her at the time of uterine at the time of fetal anomaly uterine artery Doppler as well, and further monitoring uterine artery Doppler will decide. Please check the difference. If papa comes abnormal in first trimester, we will go for option which will show choices of invasive test. And if in after actually first trimester, then we will pick options which will give us choice of high risk pregnancy monitoring, right? Timeline here is important. Yes. Yes, you are right. Okay. So it's C. So it's not C. We will do B. I also make wrong choice here. Right? B. Agree? Right now it's B. And later it will be uterine artery Doppler and then growth scan. This is important and very interesting question. Please let me know if you you feel this is clear, and if any doubt you can discuss. Should I explain it more? Yes or no?
No.
Write in chat box. इस हाँ का मतलब क्या है और एक्सप्लेन करूं फाइजा? Explain. Okay, chilling. So we said that she came at first trimester, so papa is low. Low means less than 5th percentile and less than 0.4. It's low, right? So if she is coming at 18 weeks and her amniocentesis is done and it's normal, but next will be uterine artery Doppler. Got it? That will be key. H. Because low papa is marker of high risk condition, which will put her at high risk of being FGR. Right? High risk factors of FGR. Like they said, papa less than 5th percentile. Just check on Google. Less than 5th means less than 0.4. And here it is 0.39. It means it's low. There is no fun of monitoring a baby who is having Down syndrome or Turner syndrome. Low papa means just take. Just give me 1 minute. I'm searching some. Detected from their fetal screening test, and they said alone isolated low papa is marker of FGR, not aneuploidy. And here it is isolated because HCG is normal and T is normal. We will say this is isolated low papa, right? So serial growth scan will be fine. Key here. Isolated low papa is marker of high risk FGR. Apology for this, because here they have clearly given anti-normal, HCG normal. And if they said anti 3.6, cutoff is 3.5, which is abnormal. And with this papa is also low, then this is not isolated low papa. This is perfectly matching with associated markers. Means aneuploidy pattern. So here we will do aneuploidy test and it will be TVS. Isolated papa, FGR, and papa low with other marker of aneuploidy, then invasive test for aneuploidy, right? आवाज नहीं आ रही, अब आ रही है? Is it clear now? Yes. Okay. Now we are very close towards end of the session. 41 primary gravida, 16 weeks. Worried about small baby. What is the appropriate plan? 41 means she is having intermediate risk factors. With intermediate risk factors, what we will do? Growth scan from 32 weeks. One basic scan, right? At 16, not at 16 weeks. Basic scan should be done after 24 weeks. Any basic scan for biometry is reliable. And also we will check biometry in intermediate risk factors at the time of anomaly scan, right? See, biometry we can check. Here, this is intermediate, means her patient age is 41. So she is positive for intermediate risk factor. We will assess her for placental disease for indication of Loprin, and we will do an anomaly scan. And with anomaly scan, we will check her estimated fetal weight, right? At 16 week, we do nothing. And in available choices, the best key is 32. This one. D. 32. Clear? Yes. Okay. Now think about 30-year-old patient, less than 10 centile SGA on ultrasound 32 weeks, umbilical artery is normal. So this is just SGA. What we will do in SGA? This is, now you will understand this, that in SGA, we do growth scan and Doppler every 2 weeks. We don't actually leave SGA proven cases without monitoring. We monitor them with Doppler every 2 weeks. Clear? Yes, A. And why? C. इसको बड़ा कर देते हैं. We are here. No, we are here. Sorry. We are here. Less than? No, no. We are not here. We are here. Here. Less than 10 centile. I think this picture is not appropriate for this situation. This is for high risk. It should not be there. I attached it wrongly. She is having SGA. Just 1 minute. No, no, no. This is okay. Fine, fine, fine. Yes. Story begins from here. That if in current pregnancy estimated fetal weight is less than 10 centile, what you will do? This is also marker of high risk condition. Are you following my precursor here? And because of this, you will do her uterine artery Doppler here. Right? That's why we are not leaving her without monitoring. Yes. So late onset SGA because she came after 32 with normal Doppler, still SGA. So we will monitor her 2 weekly. Now, fetus measures less than third centile at 32 weeks. Earlier anomaly scan showed less than third centile. That is okay. That is repeat question. We have already done that. If at the time of anomaly scan, severe growth restriction, we should have amniocentesis. We should do amniocentesis. Okay. A woman at 32 weeks has an estimated fetal weight and abdominal circumference less than third centile. Means FGR and uterine artery Doppler is also abnormal. But Leica is okay. But Leica is not decision making. It's late FGR with abnormal Doppler. Now they have not said as that what kind of abnormality, absent reverse or only PI more. So as this is a recall, that's why I am giving it a benefit of doubt. You can't actually make any key otherwise if they are not telling us about the nature of derangement. So key will vary. It can be any. If absent at 32, then maximum 34. If reverse, then maximum right now. And if it is only PI more, then maybe before 37. Right? So eliminated key you can make here. It is do nothing wrong. Steroids and deliver immediately wrong. Fortnightly Doppler can be right, can be wrong. We don't know. Weekly Doppler can be right. But no. This for sure it's not fortnightly. We do it can be E, right? Why E? No, why C? There is no point of opting C. Either D if it is borderline, or E if it is pre-critical. And we don't know what kind of derangement. Pre-critical means absent, and borderline means only increased PI. Why deliver immediately? Liker is okay, only growth restricted. We don't know about derangement. Even if it is derangements, then immediate delivery indicated only when if there are associated maternal complication or poor CTG. Rest in every situation we have to go steroid, give steroids. Don't make any. It could be reverse as well. Even if it is reverse, then in reverse we don't deliver immediately. We give her steroid. We give her steroid. So look at word immediate. Shamsa? Now, should we move? We have put so much effort in understanding the FGR. Now I can't actually tolerate if you are actually messing up with keys. Then why we put so much effort? We can just, quickly go through like all others. Twice weekly. It can, now they are assuming this derange. I am myself correcting it so that it will not be like that. It is absent. Right? If it is absent, then it is twice weekly. Right? Because it is then terminal or pre-critical. Appreciate this difference. In any kind of FGR, see, growth is fortnightly. Because before 2 weeks, we can't pick the difference. Right? And this is not relevant here because we will only say weekly, twice weekly, or alternatively if we know if it is borderline critical or pre-critical, right? That's why I am not actually liking this table very much. It make you confuse. Okay. Next we have done. Okay, now coming towards the point which I had told you, that there is a difference between lowering dose and indication and timing if your basic intention is prevention of FGR or prevention of preeclampsia. So this is a guideline here. I am adding it here so that you can read it easily. So, what they said, NICE recommends aspirin 75 to 150 daily from 12 weeks until the birth of the baby. And basically, NICE covers hypertension. That's why. And in hypertension, the basic intention is prevention of preeclampsia. So here the dose is 75 till 150 for prevention of preeclampsia. And preeclampsia more happen near delivery. So until birth, they give to the birth of the baby, they give to reduce the risk of hypertensive disorders related to the placental dysfunction. But if in women with previous FGR, including those born preterm, clinicians should determine whether placental dysfunction may have been a contributory factor. And if so, advise low dose aspirin 150 milligram till 36. And it is more effective if you take it at night. Yeah, here they have not written 36, but in the next slide page they have written 36. So for placental dysfunction with previous FGR, the dose will not be 75, it will be 150 milligram at night till 36. This is the difference. If patient having some problem in hepatic and renal function, then we can reduce the dose till 60. Clear? So basic intention if is prevention of preeclampsia, dose 75, 150 till plan till until the birth of the baby. In women with previous FGR, or to reduce the risk of FGR in this situation, then dose is 150 and till 36. That thing or difference, I think now clear? Okay. It will affect your a lot of questions. See. So NICE says if patient is having hypertensive disease in previous pregnancy, CKD, chronic hypertension, autoimmune disease, type 1, type 2 diabetes, sickle cell disease, right? We will give them. To prevent the preeclampsia, we will give them till delivery. And SGA says previous placental mediated fetal growth restriction, then we will give. Okay, so I am giving a scenario. Patient is having previous FGR because of placental disease. Now again pregnant. Now again at 12 weeks. What is your plan? Low pre 150 till 36 or low pre 75 mg till delivery? What you will pick? Shamsa? Yes, because previous placental mediated fetal growth restriction, if there is, then we will give high dose until 36. But if any other complication which is putting patient at risk of preeclampsia, then do not stop at 36. Give her till delivery. If alone, previous placental mediated FGR without actually existing hypertension or previous hypertension, then don't stop at 36, please. Because we have to respect maternal complications as well. We don't let our patient to develop preeclampsia after 36. We will stop it. Women at risk of preeclampsia and or placental dysfunction should take aspirin 150 milligram 12 per 36 weeks of pregnancy of regular their chance of SGA FGR. But our NICE says at risk of preeclampsia, and if it is high risk of preeclampsia, then till delivery. Only, so how we will modify these two guidelines, because one is NICE, one is GTG. We respect both, and both are opposite here. So if intention is reduction of FGR, opt 36. If intention is to prevent the preeclampsia, then do not stop at 36. This is the only solution. This is the only solution which we can actually negotiate. Otherwise, where we will stand. And in conditions where patient is having APLS and recurrent miscarriages, then we have to give Loprine and obviously heparin as well. That is another situation. So remember, 32-year-old patient booking at 10 weeks visit. She previously delivered a baby at 35, below third centile, means previous FGR. And placental histology confirmed the placental insufficiency. she is normotensive and she has no renal disease and she is not diabetic, means no risk of developing preeclampsia. So we will give her heparin 150 daily at night from 12 weeks till 36. We will not stop it. But what if she is having additional existing hypertension or previous hypertension? Then we will surely give her till delivery. Now I think with this question you have, better visibility. Similarly, see another question. 38-year-old patient primary care attends for booking at 11 weeks. Her BMI is 36. Her mother had preeclampsia. She has no history of hypertension, renal disease, diabetes. What is the most appropriate prophylactic management? Okay, so one risk factor her weight and one is her family history in first degree relatives. Two moderate risk factors means she is at risk of developing preeclampsia. We will give her Loprin till plan of, till delivery, till until birth. As her weight is more than 35, so we will give her 150 milligram, because obesity on Green-top guideline says if BMI is more, then don't give 75. That's why we are giving her 150 milligram. And the range is 75 to 150. So if patient is obese, we will give higher dose. Okay, what is the most appropriate prophylactic management in this pregnancy? Where is the pregnancy? Now 6 plus 5 weeks, she has had 3 consecutive first trimester miscarriages. Investigation confirms APLS with persistent lupus anticoagulation, which is positive after 12 weeks. She has no personal history of AT. Now this is another situation. Here we will not only give Loprin, because APLS is independent risk factor of preeclampsia as well. So you will think only Loprin. No, she is at having recurrent pregnancy loss. We will give her heparin as well. Heparin standard dose is 40 milligram in such cases, right? So aspirin. And at the start of conception, not at 12 weeks, even at 6 plus 5 weeks, because it APLS with RPL positive or recurrent pregnancy loss is positive. And in APLS, we know we give Loprin and heparin till 34 weeks. So somewhere we are giving till 36, somewhere we are giving till 34, and somewhere we are giving till 30, till delivery. So appreciate their differences, and definitely they will test you, they will touch these things. And if right now you are very clear, then only then you can appreciate. Otherwise, everywhere you will mark until birth, until birth, until birth. But in recurrent miscarriages, Green-top guideline, they clearly mentioned in APLS recurrent miscarriages, you can stop, you can consider to stop at 34 weeks. Am I clear here? Am I clear? Sorry, I have taken a lot of time on this topic because I don't want to face any complication issues, controversies in exam. People do a lot of error here. But my students, no way. So, SGA and twin, we already know criteria is slightly different, because then one additional feature which is difference actually more than 25%. Two out of 3 criteria should meet, one this and one any of these. And this is very important slide. Nobody is going to actually teach you like that. I have made you as simple as it is. There are 3 type of FGR, 1, 2, and 3. 1 means end diastolic flow positive. When end diastolic flow is positive, baby is compensating, baby is stable, prognosis is better. In single, we deliver at 36 plus 6, but as it is twin, so we will deliver at 35 plus 6 maximum. And in single, we can deliver via NVD, and in twin, if first is cephalic, we can do NVD. How we will monitor? Growth 2 weekly, Doppler weekly, because it is selected SGR with PI positive, and we already know in borderline we do weekly. But with type 2 and 3. Type 2 means persistent, absent, or reverse. 3 means intermittent, cyclical, absent, or reverse. Basically, you will think intermittent means sometime positive, sometime negative. This is good. No, this is bad because this is unpredictable. Here, sudden fetal death occur. That's why it is in hierarchy, it is higher. And if it is persistent, it is predictable, at least for cerebroplacental resistance. In both, we do growth at least 2 weekly and Doppler at least weekly. At least weekly in 2 and 3, even more frequently, as per fetal medicine recommendation. And as it is, because it is absent and reverse and early, we can add ductal stenosis as well. Obviously, in monochronic, we do MCA as well, right from 20 week because of TAPS. We will read TAPS, and you must have done earlier as well. But whether it is 2 or 3, we will deliver. If everything goes okay, fine, no complication, with this monitoring, we can prolong pregnancy till 32 weeks. And we will do section here, 2 and 3 section, 1 NBT, provided that first twin is cephalic. If not cephalic, then here 2 section. So growth scan in all types, I already told you at least 2 weeks, like single, because before 2 weeks, it will be difficult for radiologist to appreciate any difference. Doppler, do umbilical artery, and MCA weekly. If borderline are positive and diastolic flow with increased FPI, and 2 and 3, we will have to add ductal stenosis as well with MCA. And if MCA and as 2 and 3, so definitely computerized CTG for short-term variation, which you already know, this is same. So your face like this now. So a woman with a monochronic diamniotic twin, 32 weeks, twin B is smaller, ultrasound shows 28 difference. It is more than 25. Smaller twin is less than 8. 2 parameters meet. This is confirmed selective FGR. Umbilical RD Doppler in smaller twin positive, type 1, normal. Liker, normal MCA means no taps. What is the most appropriate monitoring? What is the most appropriate? I just told you. This is growth scan 2 weekly or fortnightly and Doppler weekly, planned birth at 34, maximum 35 plus 6. This is your recall as well, and recent recall as well. Type 2, monochronic twin 29, third centile, estimated fetal weight is more than 25, means 30th, and persistent, absent, and diastolic flow means type 2. Type 2 at 29, and we have to deliver at 32. So till that time, we will monitor. How we will monitor? Weekly. Fetal medicine care, growth. Twin, monochronic, if complication, always manage them with fetal medicine. Right? 2 weekly growth. Weekly or more frequently Doppler, including ductal stenosis, planned but by 32 weeks. And here type 3 means intermittent, absent, and reverse. This is type 3. Type 3, 30 weeks. So we know fetal medicine care, close Doppler surveillance, including ductal stenosis, and planned but by 32 weeks. Growth scan 2 weekly and Doppler weekly or more frequently, even less than week, even twice week. Right? So thank you very much for your time. Now, if you want to go, you can go. We have actually covered all twin and single FGR cases, which has been tested in your exam or which can come in your exam. This is your OSCE station. So this is also now very simple. 38-year-old patient at 32 weeks, reduced fetal movements for 1 day. At reduced fetal movements, our CTG has been done. CTG shows variability, let's assume normal, but STV 3.2. STV 3.2 and estimated fetal weight, obviously FGR, AC2 bad, PI more than 95th, but undiastolic flow present, MCA abnormal. If it is abnormal, it will not affect our time of delivery. It's just showing brain sparing, like a reduced because it is FGR. CTG on computerized scan shows reduced baseline variability, not tone standard routine CTG. And Dawes-Redman criteria not met after 1 hour. Dawes-Redman criteria means it categorizes CTG normal, suspicious, and pathological. And if it is good, this is good. If criteria not met, it's mean it is abnormal. So CTG is abnormal, showing short-term variation 3.2, STV 3.2. STV 3. Should be at 32, actually less, more equal or more than 3.5, and here it is less than 3.2. So it's mean where we stand. How you will actually manage. First of all, you will check patient having any hypertension or any complication. If mother is stable, fetal movements are reduced with STV bad, less than 3.5 as at this gestational age, PI 95th, and they have attached growth scans as well. But if you are not reading growth scan, they have given the findings, which you can easily decode. So it's mean we have time? We don't have time. Is it elective section, emergency section? No, it is elective section. Because STV is abnormal, not gross CTGs. That will be after this. This is earliest sign of abnormal CTG, means routine standard CTG is still normal. So we have time to give steroid and max sulfate. We will give steroid, max sulfate, and then we will do cesarean section in this. And many candidates have done, because PI is more than 95th. So they said we will do induction at 36 plus 6, because they have not registered this thing. Now, now clear? What was the trick in this OSCE station? They said interpret Doppler. Individually, they said interpret umbilical artery, interpret less than 10 centile, what is this? Interpret estimated fetal weight, what is this? Both are not severely restricted. Interpret this. This means this is borderline Doppler compensation phase. But what about STV? Its mean fetal heart rate are about to are complicate. So we will give more importance to STV, not this. This is just distractor here, right? So at present, end-diastolic flow does not exclude compromise. Low STV is major red flag in FGR. Dawes-Redman criteria not met. And they were asking about the Dawes-Redman, and majority students have never heard in their whole life about Dawes-Redman criteria of CTG. And it's written in your GTG, by the way. So its criteria if not met, it's mean non-reassuring. Computerized CTG. If computerized CTG is not reassuring and routine stress CTG is okay so far, which we can interpret via naked eye, means something is alarming, we don't have time, we will give her steroid, admit in CLU, repeat Dopplers, steroids, max sulfate, and we'll prepare section, right? At the same time, we will actually check patient as well. This is actually its template key. Okay. So birth is recommended. So this is cheat sheet of everything which we have done. At booking, we will categorize risk, low risk, intermediate, high risk. According to this, we will plan monitoring, and further depend on Doppler is critical, borderline, or preterminal. Thank you very much. Okay. Any query now?